Oh, well, so Tom, why does IBD need other pathways of treating patients at this point? Don't we have enough?
Well, first of all, Russ, it's great to be with you and be able to discuss these issues. As you're well aware, the prevalence of Crohn's disease and ulcerative colitis has changed a little bit. And based on more recent data from the National Health Interview Survey study that was put out in 2015, more than 3 million people over 18 years of age have a diagnosis of either ulcerative colitis or Crohn's disease. As you're well aware, there are a number of current treatments available for these patients, including the immunosalicylates, immunosuppressants, corticosteroids, and biologic therapies, including the TNF antagonists. And our goals, whenever we're treating these patients, are to induce and maintain a remission, and this remains challenging with these current therapies. On average, about a quarter of our patients fail to achieve response that's appropriate or sufficient for them. It's probably a number that's far less than that once we throw in our more challenging or difficult to treat patients with more moderate and severe disease. There's also, with many of these medications, as you know, a decrement of therapy over time. So even our best therapies really aren't sufficient to account for all of the illness that we're seeing. Illness, as you know, is associated with a decreased quality of life, substantial morbidity, even some minor increase in mortality, and a number of complications that result in hospitalizations, surgical procedures, emergency room visits. Probably most important of all, loss of time at school, loss of time at work. These are real challenges to us as treating physicians for these patients, but really much more importantly, these are big challenges to our patients. Now, the pathogenesis of the inflammatory bowel diseases, as you're aware, it's really multifactorial. Under normal conditions, gut homeostasis is obtained through a multifactorial bit of work that's done all behind the scenes. The intestinal mucosa involves gut epithelium, the gut-associated immune system, and as we're learning more about it, the gut microbiota, the flora. And all of those three things, and particularly the epithelial defenses and the immune system, in reaction to the gut in reaction to the gut flora that are there, all of that has to work in a very nice, finely tuned dance almost that occurs between all three. And in patients with inflammatory bowel disease, genetic and environmental pressures end up leading to a failure in single or multiple components of this mucosal homeostasis, results in a dysregulated immune and bacterial interaction pathway, and it's characterized really by the persistence of pro-inflammatory pathways. And current therapeutic paradigms in IBD generally involve the manipulation at various steps along this pathogenetic process. Environmental and genetic factors, there's very little we can do, and these things act early in the preclinical stages of inflammatory bowel disease, can be modified really only selected subpopulations who suffer from these illnesses, and we really haven't been able to fully target our therapies there just yet. And so we're spending much more time with the epithelial barrier, with manipulation of the immune system in an effort to correct the dysbiosis that's there. And we'll try and do things with floral manipulation as well. The majority of treatments really aim at reducing the overactive and pro-inflammatory pathways that take place in the inflamed mucosa. It's generally accomplished by blocking pro-inflammatory cytokines, primarily but not exclusively TNF alpha. We also can block IL-12 and 23. You can also block the trafficking of inflammatory cells into the intestinal mucosa. That's largely where we stand at this point in time. And it's very limited. We do well, but we can certainly do a whole lot better. And Russ, I'm hoping that maybe you can discuss with us some of the things that are going on with respect to the JAK-Stat signaling pathway and how manipulating that system might be of benefit.
Well, Tom, the JAK-Stat signaling pathway is really a fascinating pathway, and there's multiple pathways depending upon which particular JAK kinase or Janus kinase that we're talking about. We believe the JAKs play a role in regulating many things: cellular proliferation, differentiation, and immune cell functioning as well, too. The JAK-Stat pathway is a major signaling cascade downstream from the cytokine and growth factor receptors. In other words, many of the products that we look at biologic right now to treat inflammatory bowel disease end up having a receptor being stimulated or blocked. But on the other end of the receptor, on the inside of the cell, that's where the action's really happening. And the JAK-Stat pathways are responsible for the subsequent consequences, in many cases, inside of these cells. The JAKs serve to transduce the signals from the cytokine receptors. So the idea behind JAK inhibitors is to interfere with the JAK-Stat signaling. This interference is not done outside of the cell, but actually inside the cell itself. For example, the JAK may compete with ATP for binding to the kinase domain of the JAK and inhibit the various JAK proteins. So we know about JAK1, JAK2, and JAK3 primarily that have been the focus of much of the research, at least that which has reached the clinical realm. Their STAT family has 7 transcription factors that subsequently are stimulated, or in case of the medicines, blocked from JAK. Now, this is not a foreign idea right now. In fact, there already is a JAK inhibitor on the market, tofacitinib, which is used in rheumatoid arthritis and under research in psoriasis and also in inflammatory bowel disease. These are small molecules. In other words, they're pill medications, which is also interesting because most of the breakthroughs we've had in the treatment of Crohn's and colitis in the past 10 to 20 years have been through injectables or intravenous agents. So now we're moving into the realm of the small molecules, which are oral agents, and that changes the game in many different ways. So the JAK inhibition has been shown to be potentially therapeutic in IBD by especially JAK1 and JAK3 by blocking interleukin-2 receptor, interleukin-6 receptor actions inside of the cells. Now, a very nice model is shown where we can see various of the interleukin receptors at the top along the cell wall, if you will, and then the receptors going through into the cytoplasm where you can see a number of different JAK proteins might be involved. So, for example, interleukin-2 and interleukin-7 through the receptor may involve JAK1 and JAK3, while interleukin-10 is JAK1. Moving along, you can see interleukin-6, for instance, might have 3, JAK1, JAK2, and tyrosine kinase 2, and IL-12 may also have a different pathway. So many of the investigators have been looking into either a non-specific JAK inhibitor, which tofacitinib generally is. It's JAK1, 2, and 3, but primarily JAK1, 3. Or there also are investigational specific JAK inhibitors against 1 or maybe 2 of the Janus kinases. And then, as you can see on the picture, that subsequently you have the activation of the STAT and then the transcriptional changes. So these are very potent signals that upon blocking may have a profound influence and beneficial impact in decreasing inflammation that may result from patients who have Crohn's disease, ulcerative colitis, and other conditions. As I mentioned, there are some ongoing studies of small molecule inhibitors of the JAK-Stat signaling in IBD. And I'd like to highlight 2 in particular. The first one, which I referred to already, is tofacitinib, happens to be market. And the primary inhibition is JAK1 and JAK3, more so than JAK2. There's ongoing studies in ulcerative colitis as well as Crohn's disease, and they're in phase 3 studies moving quite readily along. A second agent I want to concentrate on is filgotinib. Filgotinib is a selective JAK1 inhibitor, and it is actually looked in Crohn's disease now, phase 3, and ulcerative colitis phase 3 studies as well, too. There are a few other JAK inhibitors that are in phase 2 or phase 2 to 3 testing, which are highlighted GLP-GO634, pifacitinib, and upadacitinib. So try saying that multiple times. I'm sure that given the efficacy we've already seen in some inflammatory diseases, this list will certainly just grow longer. I did mention that we have clinical data on the JAK inhibitors. Dr. Ullman, perhaps you can give us a little overview of the results so far.